Good evening, everyone. This is the part 2 of my talk on the posterior canal BPPV, the less common forms. I'll update on the newer variants of the apogeotropic posterior semicircular canal BPPV and their management with physical therapy and repositioning maneuvers. So, we need to know what is the apogeotropic posterior semicircular canal BPPV. This is the short arm of the left posterior semicircular canal painted in the red. The part of the long arm painted in the green is the portion of the arm to which the autogonal debris in the common periampullary form of posterior semicircular canalolithiasis dislocates, and that we treat with the apply or cement maneuver. That is the typical posterior semicircular canal BPPV variant. This is the non-ampullary arm, which is again a portion or the ascending arm of the long arm of the posterior semicircular canal. Sometimes the autoconal debris it gets detached from the utricular macula and gets entangled here near the crus commune in the non-appullary arm. So that is the apogeotropic posterior canal BPPV that was first described by Agus in 1995 and later elaborated in detail by Vanucci and co-workers in 2015. I upload my educational videos on my YouTube channel, which is here as under. So, the positive and negative geotropism. The positive geotropism implies the roots they grow towards the gravity and show positive geotropism. The shoots they grow away from the gravity and show negative geotropism. So, in terms of the positional nystagmus, when we do a Dix-Hallpike test, for example, the quick component of the vertical as well as torsional component beats away from the earth, so that in the right Dix-Hallpike position, if the nystagmus is downbeating and left torsional, it implies apogeotropic. This is the first research paper by the Agus described few cases of the reversed variant of the posterior semicircular canal BPPV. That is, instead of eliciting right torsional upbeating positional nystagmus, say for example in right Dix-Hallpike test, the patients were showing left torsional downbeat nystagmus, and that was slow crescendo decrescendo, and with some form of positional therapy, even the positional test, they get converted into the typical posterior semicircular canalolithiasis. This was the first paper by the Paolo Vanucci that described in detail their experience of 150 patients, of which around 20 they treated. Apogeotropic posterior semicircular canal BPP with some clinical and therapeutic consideration. In this paper, the Vanucci detailed the patients had a persistent apogeotropic downbeat positional nystagmus with slow crescendo decrescendo behavior, and it was called the paroxysmal positional nystagmus. These patients had a marked non-positional disequilibrium, and on uprighting from the Dix-Hallpike position, these patients did not had any reversal nystagmus. So these patients also had a very short latency of the nystagmus, and it did not fit into the nystagmus of the anterior canal BPPV. This is another variant by the Shigano variant described in 2020. The patients exhibited entirely opposite direction of the nystagmus from the typical posterior canal BPPV. Both in the Dix-Hallpike position and in the upright sitting position, the patient had typical characteristics of nystagmus due to canalolithiasis, such as latency, duration less than 1 minute, linear torsional nystagmus, and fatigability. Reverse posterior semicircular canal BPPV appeared after apply maneuver for typical posterior semicircular canalolithiasis. In other cases, the reverse posterior semicircular canal BPPV can be changed to typical posterior semicircular canalolithiasis. The affected sites of the reverse posterior semicircular canal BPPV were decided by those of typical posterior semicircular canal BPPV. This is another paper published in 2025, although the research was done between July 2012 to June 2016. And in 153 patients, they found that 56% reported symptoms of typical positional vertigo, 44% described postural instability during head movements with continuous sense of dizziness. So around 95% of the patients, they responded only to the brand error of exercises. So they have not made any hypothesis except saying that it is a peripheral positional downbeat nystagmus. And why it could be because of the apogeotropic or any other peripheral mechanisms. This is the latest update by Califano. He has described type 2 apogeotropic posterior semicircular canal BPPV, and according to him, this variant is because of the periampullary location of the orthogonal debris, which on repeated head hyperextension and anteflexion gets converted into the typical periampullary variant, and this we'll also discuss. So the thought-provoking question is that how the orthogonal clot remains stable in the mutable location, that is the non-ampullary arm near the crus commune. This is the orthogonal debris here. In the supine position, it is expected to transform to the typical posterior semicircular canal BPPV, and on bending forward or prone positioning, it is expected to autocorrect. But this seldom occurs. So a narrow semicircular duct or a large orthogonal clot or both is almost always present. What are the clinical consequences? Number one, non-positional disequilibrium of unilateral hypofunctioning labyrinth. Number two, relatively difficult to reposition. So this is the case one, the apogeotropic posterior semicircular canal BPPV, showing the phenomenon which was observed by Agus in 1995 and Vanuki in 2015. And this is also the story of my initial failure to diagnose a novel case that I first reported from India in 2020. Right long ampullary arm posterior semicircular canalolithiasis. So we start first with what happened on 30th January. A lady 38-year-old came with positionally triggered vertigo. The right Dix-Hallpike test shows right torsional upbeating positional nystagmus of less than a minute duration. So nothing unusual. This is a typical right periampullary posterior semicircular canalolithiasis treated with the Applet maneuver, right Applet maneuver to be accurate. Position 1, the right Dix-Hallpike head hanging position maintained for 1 minute. Then head was inclined 90 degrees to the opposite side, 180 degrees to the opposite side, maintained for another 1 minute, and then left lateral recumbent with nose down for another 1 minute. Patient was examined next day morning. The retest right Dix-Hallpike does not show any positional nystagmus, and patient is free of vertigo, and it is almost 6 years and 3 months that she remains free of vertigo. But there is a history of 7 days before consulting me, and at that time her right Dix-Hallpike test on 23rd January, it evoked a slow crescendo decrescendo left torsional downbeating positional nystagmus that lasted for almost 2 minutes. So I need to fast forward this nystagmus here. I'm fast forwarding it to 30 seconds. It is still present. Fast forwarding it to 1 minute. It is still present. 90 seconds. It is still present. And at 2 minutes, it is still present. So the persistent slow crescendo, decrescendo, left torsional positional nystagmus. So that should not happen in left anterior semicircular canalolithiasis because the nystagmus is persistent and the cupulolithiasis of the anterior semicircular canal is not reported anywhere and is not recognized by the Barani Society. So what did I do? I treated this patient as left anterior semicircular canalolithiasis with Jacobino maneuver first. Then, failing to correct her, I started the reverse apply maneuver. Reverse apply maneuver in this patient would mean that to start the apply maneuver from the right side for this presumed left anterior semicircular canalolithiasis. So, failing to respond to Jacobino maneuver during the straight head hanging test, we treated this patient with ostensive left anterior semicircular canal BPPV with the reverse apply maneuver daily 5 cycles for 7 days. She was not recovering. So, did she suffer from the left anterior semicircular canal BPPV? Successfully treated with the reverse apply maneuver over a week only to develop right posterior semicircular canal BPPV of the typical type on the day 8, that is the 30th January. No, she never suffered from left anterior semicircular canal BPPV. So why this confusion? This is the case report we did for this patient, the first reported case of apogeotropic posterior semicircular canal BPPV from India. The inhibitory projections of the right posterior semicircular canal and the excitatory projections of the left anterior semicircular canal are to the right inferior oblique and left superior rectus, which, according to the Sherrington's and Herring's law, are the yoked pair of muscles. So it generates a slow phase VOR, which is upbeating, and right torsional. The fast phase, which is a reflexive saccade, is therefore left torsional and downbeating, whether it is apogeotropic right posterior semicircular canal BPPV or left anterior semicircular canal BPPV. Apogeotropic posterior semicircular canal BPPV is reported to be 6 times more common compared to anterior semicircular canal BPPV as per the study of Califano of 2021. Therefore, I treat peripheral positional downbeat nystagmus as apogeotropic posterior semicircular canal BPPV more often than anterior semicircular canal BPPV. The rule of thumb is that if a peripheral positional downbeat nystagmus, you have ruled out a central cause from a pathology in the posterior fossa, especially the nodulus and uvula and the CVJ. If a positional downbeat nystagmus does not respond to a Jacobino maneuver done once, it is for all practical purposes not a anterior semicircular canal BPPV. So the clinical symptoms and signs in apogeotropic posterior semicircular canal BPPV described by Vanucci in his series of patients were positionally triggered disease spells. A continuous non-positional disequilibrium was the hallmark of all patients with apogeotropic posterior semicircular canal BPPV. The Dix-Hallpike test to the either side plus enhanced head hanging position may elicit downbeating torsional positional nystagmus. Downbeating nystagmus is slow crescendo decrescendo, which is also called simul-paroxysmal and is often persistent, lasting more than a minute. The torsional component, often very little, directs to the non-involved side. So, what is the basis of clinical symptoms and signs in apogeotropic posterior semicircular canal BPPV? Why do all provoking positions elicit downbeat nystagmus? Because in every provoking position, the verticality of the non-ampullary arm of the posterior semicircular canal moves the debris in an ampulopetal direction. No or short latency of downbeat nystagmus. The debris is not juxtacupular in locution. As long as the clot moves within the ampulla region, it does not have any significant effect on the cupula. When the debris enters the actual canal, a transcupular pressure is generated which determines the cupular displacement and nystagmus onset. Simul-paroxysmal downbeat nystagmus, the otoconal clot is in the non-ampullary arm of the posterior semicircular canal, which has a slower movement rate compared to the periampullary location because the canal tract in the former is narrower and shorter, resulting in friction with the canal walls that slows it down. Besides it, this is a inhibitory nystagmus because of the ampulopetal deflection of the posterior cupula. That's why it has to be a slow crescendo decrescendo. Long duration of the apogeotropic posterior semicircular canal nystagmus, otoconal clot remains partially trapped or jammed in the non-ampullary arm of the canal, so there is no reflux of the endolymph and later keep on pressing the receptors. The ampullary crest comes back to the resting position slower than normally happens. So that is why the duration of the nystagmus is persistent. Lack of reversal nystagmus in apogeotropic posterior canal BPPV has been explained by Paolo Vanucci by the lack of reversal of nystagmus explained by the canally jam model suggested by Apley in 2001. Persistent nystagmus in the head hanging position is due to complete canally jam occluding the posterior canal. So, when the patient sits up, the debris loosens and the complete jam becomes partial jam and the nystagmus disappears without reversal. Case 2 is apogeotropic right posterior semicircular canal BPPV. The geotropization occurs on hyperextending the neck. A 62-year-old male came with the history of vertigo for past 2 days. The right Dix-Hallpike test shows a slow crescendo decrescendo left torsional downbeating positional nystagmus lasting more than a minute. So what did we do next? We hyperextended the neck and carried out a repeat Dix-Hallpike test. And on neck hyperextension, there is conversion to the typical right posterior semicircular canal BPPV with upbeating right torsional typical crescendo decrescendo positional nystagmus that we treated with the Apley maneuver and patient recovered with a single right Apley maneuver. The right Dix-Hallpike retest after the Apley maneuver did not evoke any positional nystagmus and the patient was free of vertigo and so does he remains so. It is almost a year now. Case 3 is another 53-year-old male patient who came with positionally triggered vertigo for past 4 days. Left Dix-Hallpike test after a latency of almost 30 seconds. This is slightly unusual for the apogeotropic posterior semicircular canal BPPV, that is the prolonged latency described by the Vanucci. So after 30 seconds, there occurs a left torsional slow crescendo decrescendo downbeat positional nystagmus. Because the torsional component is beating towards the patient's left, it is likely to be because of right-sided apogeotropic posterior semicircular canal BPPV. But whether it is in the non-ampullary portion with partial canally jam or not, we cannot be very sure. So what did I do? I repeated a alternative positional test for posterior semicircular canal BPPV, the side lying test. So I did a right side lying test and after a nystagmus latency of 8 seconds, this gentleman evokes a right torsional upbeating typical crescendo decrescendo positional nystagmus lasting less than a minute. We treated this patient with the right Apley maneuver and he recovered in one session of treatment. Around 2 to 3 Apley maneuvers was done and it is almost 8 months now. He continues to remain symptom free. He has been given an open appointment to report whenever there is recurrence of vertigo. So the side lying position here, the head is inclined 45 degree or yawed 45 degree to the non-involved left side from position A to position B and then position C. So in the position E, the otoconal debris is here, possibly in the non-ampullary arm. And as the patient is taken to the right side lying position, it moves towards the ampulla. And as the patient is taken up to the upright sitting position again, it moves the periampullary region here as you see here in this diagram. But this is difficult to believe because if the debris was in the non-ampullary region, and if it had moved ampulopetally during the right side lying test, the nystagmus would have been still downbeating and contratorsional, that is downbeating and left torsional, but this was not the case. So there is possibly another possibility of location in such cases. Case 4 is apogeotropic right posterior semicircular canal BPPV. No geotropization occurred on hyperextending the neck. This is a lady in her mid 40s. The right Dix-Hallpike test, the speed is increased around 3 times, so the nystagmus appears like the excitatory nystagmus of anterior semicircular canal, but in fact it is slow crescendo, decrescendo, right torsional downbeating. It is left torsional downbeating, in fact. So if in the right Dix-Hallpike test, if the nystagmus is downbeating and left torsional, it is likely to be because of right-sided apogeotropic posterior semicircular canal BPPV. So as is our usual practice, we hyperextended the neck. This patient did not had a reversal nystagmus. We carried out a left Dix-Hallpike test that also showed the similar nystagmus, slow crescendo, decrescendo. This is the normal speed, left torsional downbeating. So both side Dix-Hallpike testing shows identical nystagmus pattern, left torsional downbeating, suggesting right-sided apogeotropic posterior semicircular canal BPPV. And it was in fact persistent, lasting more than 60 seconds. Any positional nystagmus, either in vertical or horizontal canals, that lasts more than 60 seconds is called persistent nystagmus. So we hyperextended the neck and then repeated a Dix-Hallpike test. But in this case, we could not geotropize the disorder. The nystagmus continues to be left torsional and downbeating. The clip speed is increased 3 times, so you are seeing an apparently excitatory nystagmus, but in fact this is an inhibitory nystagmus arising from the right posterior semicircular canal. So now there is a non-ampullary arm apogeotropic posterior semicircular canal BPPV with partial canal jam, that is called the type 1 apogeotropic posterior semicircular canal BPPV variant, first described by Agus and later by Vanucci in 2015. The another variant described is the periampullary type 2 variant by Luigi Califano in year 2021 and 2025, which on neck hyperextension and anteflexion done successively converts it to the typical periampullary posterior semicircular canalolithiasis that we treat easily with the Apley maneuver. Another variant which has come, which shows a downbeat positional nystagmus during the Dix-Hallpike testing, but it has got a reversal nystagmus, is possibly the Shigeno variant. Possibly here the otoconal debris is located in the non-ampullary arm, but without a canalage jam. That's why the reversal nystagmus is seen. So how does the neck hyperextension leads to geotropization in the type 2 apogeotropic posterior semicircular canal BPPV? The figure A shows the otoconia in the upright position in the periampullary location. As the patient is taken to the Dix-Hallpike position, the otoconia moves ampulopetally and resulting in a downbeating and nystagmus with a torsional component beating towards the opposite non-involved side. As the head is antiflexed again, the debris moves ampulofugally, and then again in the Dix-Hallpike position it is moving ampulofugally and therefore resulting in the geotropization of the apogeotropic posterior semicircular canal BPPV. So this type 2 apogeotropic posterior semicircular canal BPPV is in fact periampullary, but with a different movement compared to the typical periampullary posterior semicircular canalolithiasis. Case 5, apogeotropic right posterior semicircular canal BPPV. This is called the Shigeno variant. This is a 32-year-old doctor, came with a history of vertigo for past 7 days. Lab Dix-Hallpike test shows a right torsional downbeat positional nystagmus. In this patient, you see micro square wave jerks. So don't just confuse them. Right now, you are seeing the micro square wave jerks. And when the positional nystagmus starts, I'll just shout, here it starts. So here it starts. The right torsional downbeat nystagmus, most easily visible in the right ear. It was not persistent, lasted less than a minute. And after this nystagmus wanes away, you again see the intermittent micro square wave jerks. So whenever you do a Dix-Hallpike test and see a downbeating nystagmus with a contratorsional element, it is always recommended to observe the oculomotor responses on uprighting the patient from the Dix-Hallpike test. So reversal nystagmus on getting up from the left Dix-Hallpike test, it is now much more clear. The right eye shows, both eyes are showing, the right is showing very well. The left torsional upbeating positional, that is the reversal nystagmus. We had antiflex the head around 60 degrees to bring it to the half Dix-Hallpike position, and we'll continue to see the nystagmus as the patient is uprighted. So here we have a patient who has got an apogeotropic posterior semicircular canal BPPV of the left side, evoking right torsional downbeat nystagmus which was non-persistent in the left Dix-Hallpike position, and on uprighting the patient from the left Dix-Hallpike test, it evokes a reversal nystagmus which is left torsional and upbeating. The reversal nystagmus was notably absent in patients with apogeotropic variant of the posterior semicircular canal BPPV described by the Agas. So we uprighted here. Still, the left torsional upbeating positional nystagmus is very clearly seen. So what did we do this with this patient? We treated this with our innovated bascule maneuver where the head yacht 45 degrees to the non-involved right side. We briskly brought the patient in the nose down position, maintained this for 15 seconds, and then we carried the patient through 180 degrees to left lateral recumbent with nose up. And this sequence was repeated 5 to 6 times with the left lateral recumbent with face up and right lateral recumbent with face down, 5 to 6 times on each side. So I need to fast forward it. Maintaining the face up and face down position each for 15 seconds. The patient was evaluated next day morning with positional retest. The left Dix-Hallpike retest only shows intermittent square wave jerks. No positional nystagmus is evoked. There you see the square wave jerks without any nystagmus. We observed it for full 1 minute, and even beyond that. On uprighting the patient from the legs, Dix-Hallpike retest 2. No positional nystagmus, no reversal nystagmus was observed. It is almost 6 months that patient continues to remain asymptomatic and he has been given an open appointment. In the previous day before the vesicle maneuver was carried out, a very significant and prominent left torsional upbeating reversal nystagmus was observed. We observed the oculomotor responses on uprighting from the left Dix-Hallpike position for full 1 minute. Case 6 is again a Shigano variant, a 44-year-old male. He presented with 1 day history. In the morning at 4 a.m., he had a vertigo on getting up from supine to upright sitting. The initial Dix-Hallpike test shows a typical crescendo decrescendo right torsional upbeat positional nystagmus lasting around 20 to 30 seconds. So it is non-persistent. This patient also had a reversal nystagmus also on uprighting from the right Dix-Hallpike position, which was downbeating and left torsional. This is not shown here to save time. Right apply maneuver was carried out. Right Dix-Hallpike retest was done after 24 hours. It evokes after a short latency left torsional downbeating slow crescendo decrescendo positional nystagmus. The nystagmus looks semi-paroxysmal, that is slow crescendo decrescendo. Let us see how much time does it take to die out. So almost no nystagmus. The nystagmus has stopped before 1 minute. So it is non-persistent. We observed it for more than 1 minute. We tried to antiflex the head and then again hyperextend. This is the Luigi's method of geotropization in patients with periampullary located posterior semicircular canalolithiasis, that is the type 2 apogeotropic posterior semicircular canal BPPV. But in fact, there was no geotropization. Reversal nystagmus was also there on uprighting from the right Dix-Hallpike retest, and very clearly you see a right torsional upbeat reversal nystagmus. So a patient with apogeotropic right posterior semicircular canal BPPV with reversal nystagmus who initially had a typical right periampullary posterior semicircular canal BPPV. So this fits in the criteria or the description of the Shigeno's variant of posterior semicircular canal BPPV as of now, as we see here. Right Dix-Hallpike test showing a left torsional slow crescendo decrescendo nystagmus of less than 1 minute duration, and on uprighting from the right Dix-Hallpike position, we see a upbeat right torsional positional nystagmus. Vesicular maneuver was carried out. Post vesicular maneuver, this patient has a switch to the right horizontal semicircular canal BPPV that was noticed during the face up position of the vesicular maneuver. That is, in this case, right lateral recumbent with face up. We carried out a Guffoni maneuver which is shown here to demonstrate the geotropic horizontal nystagmus in the step 1 as you see here right now. This is weaker that was seen during the vesicular maneuver when canal switch occurred. We carried out the Guffoni maneuver position 1 for almost 1 minute, and then the head was yawned 45 degrees towards the earth, and we maintained this position for full 2 minutes before uprighting him. So the diagnostic oculomotor responses in the Shigeno variant, the otoconal debris in this case, the left posterior semicircular canal is shown here. The otoconia are in the non-ampullary arm and there is no canal jam. So in the left Dix-Hallpike position, it moves ampulopetally, generating right torsional downbeat positional nystagmus. And when the patient is made to sit, the debris moves ampulofugally. So you see upbeat nystagmus with left torsion. So that is what the Shigeno variant means. A reverse pattern of nystagmus compared to the typical posterior semicircular periampullary located canalolithiasis. What happens in the Vanucci's variant, the tract here, this is again the left posterior semicircular canal, the tract here is narrow. The otoconal debris is jammed here, possibly partially. So as the patient is taken to the left Dix-Hallpike position, there is a low pass filter effect here, and because of the low pass filter effect, you see a persistent downbeat positional nystagmus with right torsional component that lasts for more than 1 minute. And as the patient is upright from the left Dix-Hallpike position, there is hardly any movement of the otoconal debris in the non-ampullary arm because of the canal jam, and there is no pupillar deflection. That's why there is no reversal nystagmus. So apogeotropic posterior semicircular canal BPPV, the latest variant is the periampullary type 2 variant, which is easily transformable to the typical variant geotropization by serial head hyperextension, antiflexion, and hyperextension again. Even this reverse Simard maneuver or sideline positional test can geotropize, and all these are possibly periampullary in location that somehow move ampulopetally during the initial Dix-Hallpike test. When we repeat the Dix-Hallpike test with a few antiflexion and hyperextension of the neck, it gets converted into the typical periampullary variant. The other variant is here the non-ampullary, the type 1 variant. The one with partial canal jam is reported by the Agus and Vanucci 2015, for which the quick liberatory rotation maneuver, demi-cement maneuver, or bascule maneuver have been recommended by the Vanucci. The bascule is recommended by the case studies of Andrea Castellucci, the paper of 127 patients, which is still under the process of publication. And this is the another variant of non-ampullary arm type 1 posterior semicircular canalolithiasis, but here the canal jam is absent. So this is called the Shigeno 2020 variant. I finished my talk here. Thank you very much.